So what we found was a very clear result. Overall, an 11% reduction in MACE, a 23% reduction in hospitalization for heart failure or cardiovascular death, and a 37% reduction in kidney disease progression, defined as 40% decline in GFR, kidney failure, or death due to kidney disease. And those treatment effects were entirely consistent regardless of background GLP-1 receptor agonist use. Of course, there were fewer events and it's a smaller subgroup on GLP-1s, and so the confidence intervals are wider and it reflects that, but very clearly the treatment effects are consistent. And then what we also looked at was GFR slope, because there's a continuous outcome that gives us much more power, statistical power, to look at differences across different groups. And there what we found was a 60% improvement in chronic GFR slope, regardless of GLP-1 receptor agonist use, a 30% improvement in total GFR slope, consistent regardless of GLP-1 use, clear and separate benefits on all the kidney outcomes that we studied in patients receiving and not receiving GLP-1 receptor agonists. And that information probably provides the strongest and clearest evidence yet that these drugs have independent and additive effects and should be used in combination to further optimize cardiorenal prognosis. I think it's a really interesting question, and the whole role of combination therapy is going to be so important, because no one or two drugs even are going to improve or completely abrogate the loss of kidney function and reduce the risk of cardiovascular complications in patients who are high risk like those in FLOW. We're going to need a multi-medicine approach. Now, how we test that going forward is going to be really interesting. Should we be using all of these medications for every single patient with type 2 diabetes and kidney disease? Probably not, because there is such a wide heterogeneity and difference in risk of kidney failure across different types of patients. And I think what we need to be doing in practical terms is matching the intensity of treatment to their risk. So, really high risk individuals like those in FLOW, we should be trying to get them onto maximally tolerated guideline directed therapy with, a 4-pillared approach. And for people who are lower risk, patients who are perhaps, elderly without albuminuria, with well-controlled diabetes, and relatively preserved kidney function, perhaps those individuals don't need such a high intensity of treatment. So I think we're going to have to match the intensity to the baseline risk, and we're going to have to be much more creative and imaginative about the sequencing of these medications, because each of the drugs have very different effects on intermediate markers of cardiovascular risk. Like GLP-1s have much more prominent effects on body weight and glycemia compared to SGLT2 inhibitors, especially in the setting of kidney disease. So how we use those in combination is going to be an area of future study, and I think we need to tailor it to in the meantime, tailor it to the prevailing or dominant clinical priorities. And I think what we need to do, learning from the heart failure experience, is do trials of combination therapy or testing different implementation approaches. Does a rapid, intensive implementation approach using the 4 pillars improve outcomes compared to a status quo, add each additional therapy in the order in which evidence was generated if required approach? And I think that's the next frontier in CKD, implementation trials, implementation science trials, testing different approaches rather than just the individual therapy itself.